Hello, and thank you for joining us for this panel entitled Reproductive Injustice in America. This panel is presented by the Health Justice Seminar Series of the Lancet Commission on U.S. Public Policy and Health. And we have in attendance two of the chairs of that commission, Steffi Woolhandler and Dave Himmelstein. The panel is also co-sponsored by the Research Theme in Health Equity and Translational Social Science, the Rangel Social Medicine Grand Round Series, the Roosevelt House Public Policy Institute at Hunter College, as well as the Cambridge Health Justice Lab. I'm Liza Bookbinder, and I'm at the Center for Social Medicine and Humanities at UCLA, and I will be introducing the speakers. I'm going to get right to it because I want to give the speakers the most amount of time for their presentation on this critically important and timely topic. The first speaker who will be speaking, there'll be a joint presentation. Carol Joffe is a professor at UCSF's Center for Advancing New Standards in Reproductive Health, as well as a professor emerita at the UC Davis. Her research focuses on the social dimensions of reproductive health, and a particular interest in abortion provision. She's the author of numerous books, including her most recent book entitled Obstacle Course: The Everyday Struggle to Get an Abortion in America. Besides writing for an academic audience, she also writes for the general public, and her work has been featured in the New York Times, the Washington Post, the Huffington Post, and the Hill. In 2017, Dr. Joffe was awarded the Christopher Teitze Lifetime Achievement Award by the National Abortion Federation, as well as in 2015, the David Gunn Lifetime Achievement Award by the Abortion Care Network. She'll be presenting her work with Dr. Jennifer Carlin, who is a family physician as well as a family planning specialist and a professor at UC Davis. Her primary care practice is anchoring in caring for patients, particularly those who have been historically disenfranchised, in ways that encourage an empowerment and autonomy. She's also trained as a medical anthropologist and a historian of medicine, and her research has spanned a wide range of topics that address how healthcare can be delivered in ways that are person-centered and empowering, with a focus on reproductive health. Her research also aims to encourage physicians in training to approach their practices from an historical, trauma-informed, and self-reflective perspective as a way of improving quality of care and decreasing trauma caused by the medical system. The next speaker is Catherine John, who's also known as CJ. She's an activist based in New Haven, Connecticut, who works on a number of social justice issues, including reproductive rights, racial justice, and menstrual equity. She's also the lead organizer for Black and Brown United in Action, and will be speaking of her experiences related to abortion access and community organizing in New Haven, Connecticut. And lastly, Dr. Sam Dickman is the Chief Medical Officer for Planned Parenthood of Montana and the Medical Director for Primary Care at Planned Parenthood in South Texas. He's a full-time abortion provider who spent 3 years in San Antonio as a provider, and he now sees patients for primary and abortion care in Montana. He also does health policy research and is a member of the Lancet Commission on U.S. Public Policy and Health. So I don't want to take any more time, and I want to turn over the panel to Dr. Joffe and Dr. Carlin for their talk.
I would also like to please note that if you have any questions, please feel free to type it in the Q&A box below. Thank you.
Okay, great. Can everybody see my screen? Yes, okay, great. So thank you so much for this opportunity to talk today about some urgent and timely challenges to reproductive justice. Carol and I are honored to be part of this panel. We first wanted to say that we have no disclosures, and we wanted to acknowledge the participants in this study and all of those who are working tirelessly on this issue, many of which are here with us today. So for background, over the last decade, the medical community, as well as the general lay public, have become more and more interested in the fact that people are obtaining their own medications for terminating pregnancies without medical assistance. Self-sourcing and managing abortion is common around the world, where people obtain medications over the counter or use herbs to assist pregnancy terminations, or have accompaniment models in which friends or midwives or other community experts help them terminate their pregnancies safely. While these practices have been going on for decades, it has become safer and more effective with the advent of the combination of mifepristone and misoprostol, the two medications that are often prescribed together and are FDA approved in the United States for a medication abortion. So no longer does the idea of a self-sourced and managed abortion conjure up images of Jerry Santoro, who you will later see a picture of during Carol's portion of this talk, but rather of people obtaining medications that have few contraindications and few side effects, and then managing their abortion without engagement with a formal medical establishment. Some of the logos listed here on this slide are organizations that offer support to those who are terminating their pregnancies on their own in the US by vetting the pills like Plan C, by sending pills like Aid Access, and then by offering medical and emotional support like the M&A Hotline, Exhale, and SAS. So in the US specifically, studies have found that about 2 to 7% of individuals have tried to end a pregnancy without medical assistance, but this number has been expanding with increasing state restrictions and during the COVID pandemic, as it's become more and more difficult to access in-person reproductive health care. From studies about the motivations of those individuals terminating their pregnancies without formal medical assistance, we've learned that they include desires for an empowered experiences, not wanting to interact with the formal healthcare institutions to assist in a more sort of natural experience of pregnancy termination and loss, and to issues of limited access and concerns for stigma, trauma, and threats when obtaining formal care. The medical evidence robustly suggests that medication abortions can be done safely and effectively outside of the medical setting. And yet there's social, political, and financial reasons why it might be difficult for physicians to relinquish perceived control over such a medical practice. So for the last 2 years, I've been interviewing and surveying abortion providers about their perspectives, as well as observing a hotline of practitioners who support individuals who are self-sourcing and managing their abortions. I thought it was really important to figure out what these physicians think, because physicians have the power to persuade regulators, to inform public opinion, to support those individuals when they come to the medical setting if they seek care, and to decrease stigma generally about people's experiences of their reproductive lives and health. So the main study I'm going to be talking about today draws on interviews with 40 physicians who provide abortion care. The interviews and the surveys were done at 2 time points, one before the COVID pandemic in the spring of 2019, and then later during the COVID pandemic in 2020. But before discussing some of the findings from this study, I'm going to turn this over to Carol to contextualize this study within the historical relationship of physicians and abortions in the US.
Thank you, Jen. And let me thank UCLA and Lancet and the other institutions that are promoting this event. I am very delighted to speak with you at this very serious moment in abortion care. So as Jen said, I'm going to offer some context for our research on self-sourced medication abortion. I want to start by pointing out an interesting contradiction facing the world of contemporary abortion provision. On the one hand, a major story of this field for the almost 50 years since Roe has been in effect, has been the marginality of abortion care within mainstream medicines, for reasons I will shortly elaborate. And as a result, there have been numerous efforts by pro-choice doctors to promote the integration of abortion into standard reproductive health care. On the other hand, we have seen the steady rise of medication abortion since it was first approved in this country in 2000. And now it represents over 50% of all legal abortion performed in the United States. And as Jen has just told you, medication abortion also is a major method of current events as self-managed abortion. And these efforts will undoubtedly dramatically increase after the Supreme Court decision on Roe versus Wade, which can happen any day now. Medication abortion therefore heightens the demedicalization possibilities inherent in abortion provision. Now let me give you some historical background on how we got to this contradictory moment. Next slide, please. Okay, as Jen already mentioned, this is Jerry Santoro. And this is from the picture, I'm forgetting the date the picture was taken, but this was from 1964. This is one of the most iconic pictures of the pre-Roe era. Jerry Santoro was a divorced woman with 2 children. She became pregnant and she and her boyfriend went to a motel where he tried to perform an abortion. When it didn't work, he fled. The housekeeper found her the next morning. This is a police photo that somehow became public. And to this day, you can see this picture displayed at pro-choice marches. It was incidents like these that intensified the demands of social movements, both of physicians and of feminist health activists, to legalize abortion. As we will suggest later, photos like this will most likely not be the iconic photos of the post-Roe era. Rather, I fear it will likely be of a woman in a jail cell. Okay, next slide, please. As I've just suggested, seeing the horrible results of abortion done by so-called butchers, whether lay persons like Santoro's boyfriend or incompetent doctors, or actually women's very own, often very dangerous attempts at self-managed abortion. The coat hangers were not just a metaphor, they were real. The AMA in 1970 voted to liberalize the conditions for legal abortions. And recall, 100 years earlier, it was the newly formed AMA that led the campaign for criminalization. But as you see, this reversal was not without ambivalence on the part of some. As this doctor's quote makes clear, even before the advent of medication abortion, some within medicine were already concerned about the demedicalizing aspects of abortion in the sense that it diminished the traditional authority of the physician. Even the revered Dr. Alan Guttmacher was concerned about doctors becoming, as he put it at a meeting, a rubber stamp for patients seeking abortion. Next slide, please. The first quote you see here is from a doctor I interviewed some years ago who provided illegal abortions in Philadelphia before Roe. He was among those whom I have termed, quote, doctors of conscience. That is, competent and compassionate doctors, successful in mainstream practices, who provided illegal abortions out of sympathy for the desperate situation of women facing unwanted pregnancy. He explained that his family's revulsion toward abortionists was not about the morality of abortion, but because of the unethical and incompetent back alley butchers of that period who dominated mainstream medicine's understanding of pre-Roe abortion provision. The second quote made some years ago from my UCSF colleague, Dr. Phil Darney, reinforces this point and helps explain why medical institutions were so slow to start abortion services immediately after Roe. Now, as a result of these historical factors, ever since Roe, pro-choice physicians have worked tirelessly toward the goal of legitimizing abortion as part of mainstream medicine. For example, by creating a specialized fellowship in complex family planning, by securing philanthropic funds for OBGYN residency training, by creating an academic organization, the Society of Family Planning, and by encouraging publications on abortion and leading OBGYN and family medicine journals. All of this to further the argument that abortion needs to be a routine part of reproductive health care. And this brings us to the challenges currently posed by self-sourced medication abortion, and Jen will take over from here. Thank you.
Thank you, Carol. So that historical background that Carol provided contextualizes this current analysis. And here's what we found out. So it basically,
And I think you're muted.
You're muted, Jen.
sorry, thank you. So thank you, Carol. So that historical background that Carol just provided contextualizes this current analysis. So here is what we found out. So at baseline, about half of the cohort was fully supportive of the expansion of self-source medication abortion, and half of the cohort were ambivalent. Those who were from more restrictive states were more ambivalent and nervous that the known low risk of an unintended outcome might curtail abortion rights for all, not because they considered it a medically risky endeavor, but for political reasons. Specifically, they worried that the anti-abortion movement would use it as fodder to promote further restrictions. So then with the COVID pandemic, we learned that many of these physicians directly witnessed and experienced the expansion of telemedicine models, of medication abortion without in-person assessment in their own clinics. And so when I asked them later about their support of self-source medication abortion at that second time point, almost all of them but two had changed not only their explicit support for self-sourcing, but they also changed the language that they used to describe self-source medication abortion to words that expressed a more empowering experience rather than one done out of desperation. So in other words, the COVID-19 pandemic allowed these physicians to see different models of care enacted safely, which reassured them that the models actually worked in practice. Now, many sociologists of medicine have remarked that doctors learn from personal experience, so this is perhaps not that surprising. But what's even more interesting, however, is that many of these respondents reported that the experience of the first interview itself led them to view self-source medication abortion more positively. They mentioned that the activity of reflecting on their own values allowed them to let go of once held beliefs that no longer aligned with the medical evidence, nor their commitment to supporting accessible, patient-centered care. So we argue that this heightened social consciousness of these providers has encouraged this group of physicians to illuminate how medical expertise is shifting, likely not just in abortion care, but possibly in medical care more generally. So the two most prominent themes that emerged from the interviews and surveys were regarding concerns over safety and seating control, as I just mentioned. The issue of safety of self-source medication abortion is unsurprisingly a key concern for these medical doctors who've taken an oath to do no harm. But we also found that some of them expressed struggles with relinquishing this sort of traditional role of the physician. So here's an illustrative quote of that concept. Quote, "That's the problem with this self-source medication abortion. I'm a doctor. I wasn't trained to let people to do things at home without my input." Most participants, however, believe that the demedicalization of abortion care can occur safely, as illustrated in the second quote, which appropriately relocates the locus of control and expertise and the assessment of risk from the physician's perspective to the lived experience of the pregnant individual. And this physician said, "These things are happening regardless. And why not be able to do it in the safest way, like support women in this process instead of criminalizing them? Give them an avenue to do it in a safe, healthy way. Allow them to live a life that they're trying to live with control over it." And yet, even of those physicians who in principle acknowledge the safety, legitimacy, and potentially empowering experience of self-source medication abortion, some were still reluctant to give up clinic-based care because, consistent with research on abortion provision, they find that this work is just so deeply meaningful. So here you see an illustrative quote about that from a family doctor who provides abortion-based care within their primary care practice. "As a family doctor, we want to be present for events that happen in our patient lives. I think it might be a little sad for some primary care doctors to have this event taken out of that space." So after acknowledging the medical safety of the practice and then reconciling that their own risk tolerance was different from individuals who were doing self-source medication abortion, and then relinquishing control of the practice, these physicians expressed the most concern over the legal consequences of self-source medication abortion. Mainly, they worried about the criminalization of individuals who were terminating, but also worried that they would not be able to meet the obligations of caring for patients who came to them without legal and criminal consequences for themselves. So one participant advises the medical community as follows: "Doctors need to know that they don't need to report this to the police. Unfortunately, that's happened, as we know nationally. Women have gotten into trouble because emergency room staff have called the police. So while we won't likely see those images like the one of Jerry Santoro dead in a hotel room after Roe, many expressed concern that they would see news articles about people being arrested for being pregnant. So finally, when these physicians in this cohort were asked to delineate the aspects of an ideal scenario of abortion provision, here's a list of what they said. And after outlining these ideals, the physicians in this cohort who were ambivalent at the beginning of our study realized that self-source medication abortion met all of these criteria for an ideal abortion. So how could they not support it? When asked specifically about what it would take then for the demedicalization of medication abortion to become a reality, participants did not mention that they wanted more evidence of the safety or efficacy, which they thought was sufficient. The one caveat of that is that they noted a lack of evidence about the satisfaction of the experience for patients who self-source pills. But instead of more evidence, they argued that a change in the culture of medicine was needed. They thought that providers had a responsibility to advocate for the decriminalization of abortion generally, and self-sourced medication abortion specifically, and to encourage support among clinicians, pro-choice advocacy groups, and professional medical organizations. So how is this acceptance of the demedicalization of abortion reconciled with those earlier efforts of pro-choice physicians to promote abortion as part of normal reproductive health care within the medical institution? So on the one hand, one way to manage the stigma of abortion care is to claim expertise, which is what we saw physicians doing in the past and which Carol described. On the other hand, the other way to manage this paradox is to normalize abortion provision by changing the kind of knowledge the practice requires. That is, to promote self-source medication abortion as accessible and safe self-care, which is what we see our participants in this study doing here. This endorsement of self-source medication abortion, however, does not come without ambivalence. As we have shown, contact with patients is a deeply satisfying aspect of abortion provision for those interviewed, and they acknowledge the significant trade-off involved were they were to give this up. So in conclusion, the crisis in abortion care in the US has compelled physicians who provide abortion care to re-examine their values and to challenge the historical notions of medical expertise. We suggest that our informants were led to this professional and personal soul searching due to the highly politicized nature of their work. However, it's quite possible that what we're pointing towards here is a more general trend among a subset of contemporary social justice physicians of questioning who benefits from control and expertise within the profession of medicine more generally. Certainly, the change in our informants' perspectives after they struggled with the tensions in their value systems speaks to the importance of reflective work and values clarifications within the medical profession itself. So thinking about the future landscape of abortion care in the United States, as we are on the precipice of abortion becoming banned or severely restricted in about half of the states, it is clear to us that self-source medication abortion will become even more widely utilized. To what extent abortion providers will be involved in this phenomenon, and what will be the legal ramifications of this involvement remain to be seen. So we end by urging others to respect and follow the lead of these perspectives reported in this study, and to work towards demedicalizing abortion as a way of destigmatizing and de-traumatizing reproductive and sexual health. If these doctors are willing to give up part of their practice that they have found so deeply satisfying and important, and that they're willing to even question their own roles and their expertise to support it, we hope this will inspire others to do the kind of deep introspective values clarifications necessary so that they can support and trust those individuals who are doing what they deem is safest and necessary for themselves given their own life circumstances. Thank you very much. I'm going to end that slideshow. Yeah. And now I don't know if I pass it to Liza or to CJ.
You can go straight to CJ.
Thank you so much. Thank you all for having this event and for inviting me to be part of this. This is amazing. And thank you for the information just shared. That was really, really amazing and quite pertinent, especially now. You know, in Black and Brown communities, we have been denied access and opportunity to basic essential needs from the beginning of time. And you know, the reality is forced motherhood is enslavement. If you would see as far back as slavery, women were forced to have children. Why? To carry on the tradition of slavery. Angela Davis spoke to mainstream feminism, citing that those who are fighting for privilege while having privilege, what are we really fighting for? You know, we should really be recognizing the voice of those who are voiceless, right? Perfect. Thank you. Thank you. Thank you very much. Here we see Faye Wattleton, the first Black woman to serve as the president of Planned Parenthood. She condemned the decision made by the Superior Court regarding Webster versus the Reproductive Health Services. This was a decision that allowed states to limit abortion access. In my talking to, you know, having access to abortions and community organizing, the limitation of access will also limit the community. And because, going back to what Angela Davis said, the mainstream feminism, where we have, it's led by white women and constructed around their ideals, including the stigmatization of Black and brown women. Where do we fit in? Where are our voices heard? And yet we see historically that we are ever more present in the fight. Yamani Hernandez, the executive director of the National Network of Abortion Funds, recognized the historical restrictions and oppression of Black and brown women when making decisions about their bodies. As you saw before, historically, we were never allowed to make decisions about our bodies, but yet we were required and condemned to whatever was decided for us. When did we get a chance to share our voices, our experiences, our thoughts? Even if you were to look at the data itself, where do we fit in? Where are our numbers? Where are our voices? Right? And again, this is because we were limited access. And because we were limited access, up to and including where abortion clinics tend to be located, you know, it's not exactly the best scenario. Right here in New Haven, Connecticut, there's a weekly protest of anti-abortion believers, you know, and they stand there with pictures of fried chicken, and they try to convince the whole world that this is horrible and your uterus will fall out of you if you have an abortion. What do you say to the young woman who just had a traumatic experience, who found out, or any woman or anyone who, you know, can have an abortion, and they found out that they were just about, you know, they have this situation? What do? How do you address that? Right? These are questions that we have to really acknowledge, because when we speak about the oppression and the lack of access in Black and brown communities, so far in most of the protesting and the marching, you're not seeing us. This is something that pertains to us in so many ways, right? Yet our voices, especially our Black trans voices, are silenced. Flo Kennedy, very sassy lady, and she spoke to it. Now, she was the second Black woman to graduate from Columbia Law School. Unapologetically dope. She fought for the Black Panthers, you know, and she recognized that everything, including our own right for our own bodies, is controlled, you know. And if a man had the opportunity to, would we be having this discussion? White men made the rule that we cannot have decisions on our own bodies, and they also get to decide what we get to decide. And that's not slavery. I think we have a lot to discuss here. The list could go on and on. You know, I mean, there's so many prolific women who have fought, especially Black and brown women, who have tried their hardest to say, listen, we are here too. And still, as mentioned before, in the time now, where are we in this discussion? It's bad enough that many clinics are located in areas where we would not necessarily go to. For example, the one that I just shared, the Planned Parenthood nearby. But even in the advocacy for the rights on our bodies, where are we in that? We saw the marches, we saw all the arguments, we saw everything, but where were we? Were we represented? Or was it more so, as Angela Davis pointed out, those with privilege fighting for more privilege? So what really changed? Yes, sure, you could go on to that slide. Thank you. What really changed? You know, I come from Trinidad and Tobago, a small island that looks like a Timberland boot, you know, a simple people. And I have heard stories and, you know, known women and those who identify as and who can have abortions, you know, going through some real horrific things from rape to being molested, domestic violence, and finding themselves in a predicament where they're trying to get access because they don't want to continue. What about those who have medical situations? You know, there are situations where you physically cannot go on. But at the bottom line, when do we as Black and Brown women get to lift the knee off our necks and make choices, right? When do we get to say, you know, enough is enough? And when would our voices matter? Are we supposed to always follow the march, or could we lead it too? Right? Again, in the advocacy of this, it has been white led and the stigmatizations that follow. One of the most oppressed groups are Black and Brown trans people. And where are they in this fight? And where are their voices? Right? So there's just not one community. And these all connect to why you don't see many Black and Brown people coming out in these marches. Because if we are not present at the table, why would others want to sit there? But it has to start somewhere, right? We have to recognize these things. Very great freedom fighters, Black and Brown freedom fighters have done some real phenomenal things, you know, to fight for our voices and our rights. Right now, we're in a time where it's easier to find an AK than it is to find formula or tampons. When will the attack on Black and Brown women stop? When will we say enough is enough? When will we recognize that Black and Brown women are valuable? You know, as Ashley Ashwood Garvey pointed out, the first wife of Marcus Garvey himself, a Jamaican Pan-African freedom fighter. A nation without great women is a nation frolicking in peril. Black and Brown women are great, right? We recognize the things in our community. We are bearers of life. Yes, but we should have the choice as to what we can and cannot do. Shouldn't we have that choice by now? After years and years of being enslaved, who do you think is really going to be most affected if this is to go in that direction where access is severely limited? Think about it. Who do you think will really be most impacted? In the Black and Brown communities, mostly there are women working, most especially right now, especially in the now. Most men are unable to find jobs. That's where you find all the joblessness, you see? You find that the women are the ones bringing in the funds. Okay, so what are we supposed to do? Continue it on if a woman decides that, you know what, I have to live within my means? Shouldn't she have the access and opportunity to resources to do so, regardless of the color of her skin or her gender identity or her culture or her class? Shouldn't it be that she should be able to say, I don't want to do this? When will we say the white man's way? We're done with that. We're finished with that. This should not even be a conversation at this time in history. And one has to wonder, was that in itself planned, right? Why right now where the cost of living, I mean, I don't know about you and how much you know about Connecticut, but it's very expensive to be poor here. It is very, very expensive, you know, and it is even harder that we live in a time where women have become desensitized, especially Black and Brown women. We are expected to be resilient. We are expected to be strong. We're not supposed to hurt. We're not supposed to complain. When we do, we're emotional. We're supposed to be angry all the time. I'll tell you about myself. I decided I'll be the happy little Trinidadian Black immigrant person. I don't want to fall under that facade, that stigmatization, that franchise way of thinking. Now, just as we're talking about the production of tampons and formula, there is also a monopoly on abortions, isn't there? We got to pay attention. When will we say enough is enough with attacking women? But then too, that will lead into a discussion of what does feminism mean? What is feminism to you? Is it only the white women leading a march with hats on? Or is it more than that? I think it's way more than that. You know, we have to realize that we should all be feminists and that a man can be masculine and be a feminist. We need to stop with the traditional white ways of classification and deciding who gets to be whom and when and how. Again, back to what I just mentioned, Black and brown women are expected to be resilient. If we say how we feel, we're emotional. If we react, then we're being sensitive. But if we don't say anything, we're angry. When do we get to be ourselves? Why is it not okay for us to express ourselves? Why is it not okay for us to recognize that we are not being treated well, much less even being brought in to represent ourselves? So again, in speaking on my experience as an activist and having access to abortion and community organizing, this is a topic which is very sensitive yet difficult within our communities because there are many cultural, class, gender, race restrictions which apply to us, right? Again, growing up in Trinidad and Tobago, you know, you weren't a good girl if you had an abortion. I know several women personally, persons who identify as women, who have had, as we would call, backyard abortions, which were really dangerous. And I know of one who actually, she cannot have children now as she's older. And you know, why are we still judging people? If I decided to have an abortion, that's my business. That's my choice. That's my right. Aren't we supposed to be free? This weekend, we're supposed to be recognizing Juneteenth. What did we really learn? Or do we think that just because we have a sprinkling of Black and brown representation here and there, that we did enough? When are we going to realize that it makes sense to recruit, train, and hire Black and brown social workers, teachers, leaders, managers, legislators? When are we going to realize that it makes sense to make it easier for Black and brown legislators to even qualify and, you know, have a campaign and represent us? Everything in America is determined by money. Where there is money to be made, decisions will be had. We're okay with ripping children away from their parents at the border, but we don't care beyond that. We should be just as upset. We should be just as upset about that as we are about this, the choice of having an abortion. We should be just as upset. If you could sit there and watch parents have their children, I'll tell you something. I just recently learned of a situation that broke my heart 2 days ago, incidentally, prior to this presentation, you know, of a young lady who was held at the border and now she's pregnant. But she's also under 18, so she can't, you know, she's not being allowed to have an abortion. Now, if you know anything about what's happening at the border, I doubt highly that, you know, this happened with her friend or whatever they're going to try to cover it up as. They have everybody segregated. So you have boys over here, girls over there, men over here, women over there. So how did she get pregnant then? Was it an immaculate conception? I don't think so. But when are we going to really hold people accountable? As stated in the chat, when are we going to be free? And what does freedom mean to you? Again, looking at this fight right here, you know, you have to realize that what's been happening thus far, where are we in that? Where are we? Are we being represented at all? We see all the rallies, we see all the fighting, you know, the freedom fighting. Again, is it another situation of people with privilege fighting for privilege? Is it what the white man wants it to look like? And why is it that just like baby formula, just like tampons, there's a monopoly on abortions too? What's wrong with this picture? I'll tell you what I know. America runs on oppression, and Black and brown women have been oppressed for way too long. And I hope that after today, we say, today is the day when we do what we can to change, because it starts now. We have to change the narrative and change the cycle. Thank you.
Great. Thank you so much, CJ, for your talk. And now I just want to turn it over to Sam Dickman for the final talk. It'll be brief, about 5 minutes.
Can you see my screen? Great. Well, thanks to Liza, all the co-panelists, CJ, that was just an incredible talk. I really appreciated that. Thanks to Steffi and David and the folks at Roosevelt and the Lancet too. So I'm Sam Dickman. I'm an abortion provider. I worked for several years in South Texas as a provider down there, and I just moved up to Montana. I'm just going to talk for a couple of minutes because I would love for there to be more room for discussion in the group here, but I'll just talk a little bit about, I mean, I think, you know, CJ, Jennifer, Carol provided just an incredible kind of historical context and some really interesting, thought-provoking frameworks about how to think about the future of abortion access. I'll just talk about what's going on in Texas right now, and then just a couple pretty concrete ideas of where things are going. So I'll be brief. See if I can click through this. Okay, so just to make it clear what patients are facing right now in Texas, and this has been the case for more than a decade because of laws that far predate the current Supreme Court case and also predate the Senate Bill 8, which went into effect last year. So this is just, you know, a subset of the restrictions, but in order to provide an abortion, you have to be a physician. You can't be a nurse practitioner, a PA, or certainly an RN or an unlicensed provider. This is, of course, for not self-managed abortion or self-sourced abortion, but for abortion in a clinic. Kind of going along with that, telemedicine abortions, which have been shown to be totally safe, very effective, and really decrease costs, are not allowed in Texas. In the same way, ultrasound, which also is completely unnecessary for the vast majority of early abortion care, is required in Texas. There's no insurance coverage for the vast majority of the patients I saw, even those who had insurance coverage, which is, you know, a small subset because Texas hasn't expanded Medicaid. But even for people who have Medicaid or who have private coverage, abortion is completely inaccessible, and people are looking at $650 or so out of pocket in order to get an abortion. That's compared to maybe $100 to $300 for self-sourced abortions online, though there are probably ways of getting it for less than that, especially if patients want to travel over the border into Mexico. There's a 24-hour waiting period, which is an enormous burden for patients in Texas. There's state mandated counseling, so I have a whole script where I very quickly say the things that I'm required to say to patients that have no basis in medical evidence. And then if a 17-year-old gets pregnant and needs an abortion, she'll need to get consent from her parents or to go through an incredibly challenging judicial bypass process. And all of these restrictions are very effective in terms of just increasing the distance that patients have to travel, increasing out-of-pocket costs, increasing the time, and really stigmatizing care. And this is just my kind of cartoonish way of thinking about this. Of course, the decision last year to ban abortions after 6 weeks really just increased all of these barriers for patients. And so we were finding tons and tons of patients who I would do an ultrasound for and then tell them that they would have to travel 20 hours round trip to New Mexico or Oklahoma in order to get an abortion. Real quick here, I don't need to tell this group, but let me just show the map of what's going to happen when Roe is overturned, which is, what we expect. Some of this is already happening. So there's currently no provision in these clinics that are in, I think there's North Dakota that already has decided to stop offering services, and there's certainly others. Abortion rates will just plummet. Abortions, many patients just won't be able to access care at all. Some of them will get self-sourced abortions. We know that they will, but that will be a fraction of the total number of patients. So I'll just finish by saying, in a short-term way, abortion funds are very helpful. They were incredibly helpful for patients in Texas who were able to use the funds that were provided by the Lilith Fund, for example, in order to pay for that $600 that they otherwise would have had to wait weeks for, and therefore would have been too late to get an abortion in Texas. In terms of advocacy, I'll just say that this is an article by a UCLA professor, Michelle Goodwin, who wrote about her own experience as a victim of rape when she was a child, and I think stories about providers are obviously important, but stories about patients are so much more important when we think about abortion access, because it's women in the South and the Midwest who are largely affected, and other people who are pregnant. Okay, that's it. I'm going to stop here. Thank you.
Wonderful. Thank you so much, Sam Dickman, for your talk. And thank you all the panelists for these incredible, very evocative, critically important and timely topics and discussions. I was particularly appreciative of CJ bringing out the voices of the Black and Brown communities, how art could be differentially impacted in the historical context of forced pregnancies, as well as hearing from Jen and Carol about self-sourced medical abortions and the stigma within the medical establishment when politics seeps insidiously into practice. And then also for Sam for showing the realities of pre-Roe abortion access and how that will change when Roe is overturned. So now I'm going to move to the Q&A session, and I'd like to start with the first question, which is, I don't know who it's from, but it said, thank you for your talk as a PhD student. So this, I think, is for all the panelists. As a PhD student focused on disabled women's reproductive health and lives, where do or does disabilities, whether apparent or non-apparent, physical, intellectual, developmental, psychological, etc., apply here or not? Where do self-identifying disabled people who often hold multiple marginalized identities fit here? Where are their voices? Why is disability and the barriers to care and choice posed not part of this discussion? It will be helpful to understand this as it is genuinely of concern. Thank you. So anyone want to jump in on that question?
I will. I think that was great feedback. I agree with that. I'm also a member of our Cross Disability Rights Alliance here in Connecticut. And what was just said is absolutely right, because that is what I was referring to when I said, where's our representation? To be more specifically, where's the representation for the Black, Brown, Indigenous, disabled, and elderly, right? Because this is something that affects people from different backgrounds. And it's true, it comes down to representation. While we are talking about something which limits, which will limit access, we're not really talking about who. We're not identifying the who involved. We're limiting that in itself. And again, here's another basic essential health need, right? Which has a monopoly associated, even down to being stigmatized as to who will be most impacted and affected by this ruling, So I just want to say thank you for that feedback. That was amazing.
I would just add to that. I mean, that this issue, the relationship of the pro-choice movement and the disability rights movement has been of concern for a very long time. Not that there's been any easy resolutions, but the two movements have been in dialogue with each other. I'm sure the questioner is familiar with the work of Adrienne Ash, who fortunately passed away a few years ago, but she was a leading disability rights theorist, but was in very active touch with various pro-choice people. Anybody, I mean, I'm sure our questioner knows her work, but other people who want to find out more, I think you couldn't do better than to find a book that she co-edited a number of years ago.
Great, thank you for that resource. The next question is for Dr. Joffe and Dr. Carlin. It says, hello, Dr. Joffe and Dr. Carlin. My background is in oral history. I would love to know more about your methodology. How did you gauge that respondents were ambivalent pre-interview? What kinds of interviewing methodologies did you use, and did you structure the interview with guided reflexive questions? I ask because I think your observations regarding the interview itself, changing physicians' perspectives, and even how their language change is very important. Thanks in advance for any detail you can provide. And to add, how did you attend to stigma in the interviews?
I think I'll answer. Excuse me. I think I'll answer first very quickly, and then I'll hand it over to Jen, who really, who did the interviews. I should make clear, Jen did the interviews that are of what was presented today. Just very quickly, the ambivalent was my analysis. I did not interview that doctor in 1970 at the AMA meeting. Because of what he said, I concluded that he was ambivalent. Anyway, but now let's turn it over to Jen.
Yeah, thank you for that question. So I developed sort of the methodology and did all the interviews. And there were two pieces of this. I published an article already about the change in perspectives pre and post COVID, and that's published in Contraception, and the article title is called Greasing the Wheels. So you can find that and read more about the methodology. And then I have another paper that's coming out that's going to be talking more about that reflective process, where people like really talked about like how did the first interview affect their second. And so the methodology will be described in that also. But just to be very brief in this setting, I did both a survey that looked at a Likert scale around asking participants comfortability with different aspects of the actual medication abortion itself. So like Sam was talking about, is like how necessary is an ultrasound, how necessary is a blood test of this type, and went through the whole evaluation and looked both at if those Likert scales changed. And then when I analyzed the interviews, I did a narrative analysis of how the participants actually talked themselves, the wording that they used, and coded it for positive terms or terms that would describe somebody doing it out of desperation. And so that was coded from the first interviews to the second. And then I just looked at like the numbers of that change. And then during the second interviews, I also specifically asked people about their mental model changes over time. And I'm happy to, if you reach out to me, jcarlin@ucdavis.edu, also happy to share more about the specific methodologies. Thanks.
Great, thank you for that. I don't see more questions right now in the Q&A. I had a couple of questions. I think, Dr. Dickman touched upon this in his presentation, but the pressing question with the impending overturning of Roe v. Wade is, what can we do as concerned public, both as lay people and as clinicians, to prepare and support abortion access in the pro-Roe era? If you could just speak to this question for all people on the panel.
The answers are not very exciting. Vote, especially if you're from a state that's not blue. California and Connecticut will do the right things vis-a-vis abortion. Other states won't. Huge amounts of money will be needed to transport people from one place to the next, from a red state to a blue state. Escorting. A lot of people will be coming to into blue states from red states, that they don't just need money to travel, they need a place to stay, they need to be oriented to a new place. So COVID allowing, if you are able to host people, if you are able to meet them at the train station. I mean, the one good thing we have going for us in this horrible moment, and as CJ mentioned, this are the local abortion funds. If you contact them, they will better able than me tell you what needs to be done or how you can help.
And do you have any specific words for clinicians? Maybe those who are not trained in reproductive health?
Well, the clinicians in blue states will be doing very likely more abortions than they're used to. The clinicians in red states will have very difficult decisions.
I mean, we should recognize that the Supreme Court is a charade. I mean, we need to attack it and recognize that it's there to protect the interests of the powerful, especially, white people, especially wealthy people. And those are the interests that got, Amy Coney Barrett and Samuel Alito and Brett Kavanaugh and Neil Gorsuch onto the court. And it's a joke. They're not our friends. You can also donate to your local abortion fund and write op-eds and try to do research on this stuff. But, the Supreme Court is a huge problem. Anyway, I'm just repeating myself.
Well, I guess I'm wondering also about grassroots efforts to circumvent it, like the things that Dr. Joffe was talking about finding ways to make networks and connections, because it will become a split nation, red and blue access and restrictions.
I mean, I think CJ, you spoke incredibly eloquently to the challenges of that kind of organizing and the history of the problems with previous efforts at real organizing for the people who are most affected by restrictions on reproductive rights. I don't know if you have anything to add.
Sure. Thank you, Sam. You're absolutely right. And speaking of the grassroots, this is for the people, by the people. And it's very daunting to organize in a space where you don't, the matter is about you, but you're not allowed in that circle. I've had it said to me before, it's almost as if with all the police brutality, protesting that's happening in Black and Brown communities, the privileged and whites took the abortion issue as a ways of taking up that space. It became competitive rather than realistic. And so what can we do to address that? Well, we could have real conversations within our communities and encourage people to speak up and encourage Black and Brown people, and not just encourage them, but truly support them. My being here today is a means of support, right? Because I'm one of few up here right now representing the many, the voiceless, those who you would not hear about. The girl who's probably sitting right now crying, probably thinking about committing suicide, the person who doesn't know what they're going to do with their life because they can't even afford to breathe right now. These are the people that need to be out there right now. And he's absolutely correct. The Supreme Court is a complete joke. The whole way that decisions are made to keep the oppressed even more. As I had mentioned before, it's very expensive to be poor in Connecticut, and it's even harder when we are not there to be represented. And this is why, going back to the point made before about voting, that is critical, but also affording Black and Brown people the opportunity and access to represent themselves, right? If I were to run for office right now, I would have to somehow fabricate tens and thousands of dollars that I probably will not find. So we have to remove the competitiveness and really decide and say, you know what, we want real justice, and the time is now.
Well, that couldn't be a better ending to this panel, and this is really just the beginning of the discussion. So thank you again 1,000 times to all of the providers and all the panelists for their talks and for bringing this to light, and this discussion will continue. I just now want to turn to tomorrow's, obviously the upcoming talk. That's going to be with Dr. Michael Mensa about why is Juneteenth a national holiday, and that will be on June 21st at 12 p.m. Again with the Zoo at Semel, which is at the UCLA Center for Social Medicine and Humanities. So thank you again, and also
Thank you, Liza.
thank you from the Lancet.
Thank you for having us.
For all.
Thank you, everyone.
Thank you. Everybody have an amazing day and weekend. Happy Juneteenth.